Hi, good morning, everyone.
Morning.
Good morning.
Okay.
Morning.
Morning.
Okay.
Morning.
Are you ready, the presenter?
Yes.
Yes, sir. Okay. You may try share your slide.
Okay. Can see the slide?
Yes. Can you go to the first slide, so that I can write down the names of the presenter? Yes. Wait. Wait.
benjamin 打瞌睡过来了，罚款。
等一下要开车了，要去太空了。
这样变小啊。
不用变小啊。
还有人没有进来啊？
哇，谁的声音这样性感，吓到一跳哦。
不好意思。
Okay. So 1, 2, 3, 4. 4-person presenting today.
Yeah.
Okay. Before we start, I just have a few things to discuss. If you check the group, right? Number 1. Wait. Let me go back. Number 1 is, okay, can you all check, all the groups here, whether your case discussion slot that is plotted in a timetable and the list is the same or not? Can you all check? Because I might do mistake, right? Because like Alex group, there is, the slot that I've plotted in the list is different from the timetable. So I need to find one replacement. So the other groups, okay, try to look at all the slots that you find in the Excel sheet. It matches with your timetable or not. And then if let's say got any mistake, you just let me know so that I can do the replacement altogether. That is number 1. Number 2. Okay, and also I already updated the physical low vision clinic that you're going to have in week 7 in the Excel sheet. Please key in the appointments that you have made because I might have additional patients also. So I can give the free slots to them for them to select when they want to come. Okay, can you help me to do that? If let's say you already make appointment for week 7 for any patients, okay, you just write down the name. If let's say they have already confirmed their appointment time and date, so the free slots I will take and give to the other patients that wants to make appointment with me. Can you all do it by today so that I can, because the patient is waiting for the appointment slot for me to give them. So later, after the presentation, when you're free, you just key in all the details so that the free slots I can give it to them. Can I? Boleh ya? Okay, that's all. Announcement for today. If let's say there is nothing else, then we can start with the presentation. Okay. So Kevin, Chingwoon, Serene, and Benjamin. Correct? Okay. Where's Chingwoon? Missing?
Yeah, I'm here.
Oh, okay. You may start now.
Okay, good morning, Miss Indila. Good morning, everyone. Today is our low vision case discussion, OPT 3515. This patient is Miss Ann, age 70 years old, occupation student, OKU card holders, yes. This patient came for next slide. This patient have 2 visits. One is January 2024 and second visit is May 2025. Okay, her primary complaint on January first visit is blur vision with current specs. And second visit, we noted that she is albinism noted and better vision is in left eye. And spectacle used on first visit is single vision transition, only used for outdoor and in class. Second visit, we noted that she already have a single vision spectacle as 2024 and multifocal prescribed but unused. And distant vision on first visit clear up to 2 meters. And second visit, we only have the info from 40 meter, right side plus 250, S675, S6110, and her VA is 6/448 minus 1. Left eye plus 100, S6 550, S600, and VA only 6, achieve 6/48 plus 1. In near vision aid, on first visit, we found out that she used handle magnifier prescribed 5 years ago as Lion Hospital and still effective. When she come for second visit, she never mentioned of magnifier during this visit. On education activity, on first visit, she attend school and still use the glasses that prescribed to view the whiteboard. When she come for second visit, she is preparing for SPM exam on November, this coming November 2025, and we noted that she sit in the middle of the classroom. The hospital follow-up first visit, we noted that her last eye exam 2 years prior UKM due to the refractive changes. And second visit, we noted also no regular hospital follow-up or medical checkup on second visit. And spectacle effectiveness, when she come for first visit, her spectacle provide limited distance clarity at 2 meter. When she come for second visit, there's no improvement with the prescribed multifocal glasses, and she didn't brought her glasses on second visit. Okay, from this patient history summary, what is our key observation is her visual limitation both visit confirm restricted distant vision 2 meter clarity only. On spectacle non-compliance, prescribed multifocal not used possibly due to ineffectiveness or discomfort. Low vision aid rely on handheld magnifier for near work, but its use was only noted in the first visit. And on educational impact, sit mid classroom and preparing for SPM exam suggests need for visual aid optimization. And there is no medical follow-up, no consistent checkup or follow-through.
I think you should change the slide.
No, this is from the slide patient history summary.
Oh,
Just
okay.
now. Okay, so next slide. Okay, after we get the info from the patient history summary, we will note that there's some missing or not recorded. First one is we find out no record of albino patient noted during first visit. During the previous spectacle prior to Lion Hospital to provide similar visual performance, is the patient enrolled in a mainstream school or a special education school? Has the patient ever been referred or received support from a MAB? What is the magnification power of the current handheld magnifier? Any known systemic health issue? Can the patient see clearly at distance of 2 meters without spectacle? Why is the multifocal spectacle not? Why is the multifocal spectacle not used? It is unhelpful, offer the same vision or difficult to use? Who prescribed the multifocal spectacle? Were there any challenges faced during exam preparation? Did the patient bring the handheld magnifier during the visit? Next. Sorry.
Yeah, okay. So for the patient's task-related history summary, so okay, in the visit one, for the outdoor activity, she quite enjoy with jogging and beach outings. And then for the visit two, she's active in sport. And then for the sun protection, right, she will she will wear sunglasses and then long sleeve and hat. And then in the visiting tool, there's no any, it is not stated in the record. So for the digital use, she will spend long hour on devices and then no visual aid use and she will be sit quite close to screen for the first visit. And then for the second visit, right, screen time will be reduced to 2 to 3 hours per day. And she used to watch TV quite close. And then for the visual aid task, right, there's no visual aid for gadgets for the first visit. And then for the second visit, she'll be used handheld 2 times of a magnifier for near tasks because it is effective since primary school. And then for the her homework, there's no any details reported in the first visit. And then for the second visit, she has no issue, and then with no additional lighting needed as well. And then for the classroom vision, there's no record in the record sheets. Okay, so for the second visit, she will feel difficulty when seeing blackboard and must sit in front of must sit in front and she will copy the her friends' notes as well. And then for her daily tasks, okay, she'll be, there's no any record in the first visit. And for the second visit, there's no any issue with homework, cooking, and face recognitions, and also color vision and mobility. So for the key observation, that's not in the slide. Okay, so for the key observations and interpretations, for the classroom difficulty, there's a notable issue in May 2025 visit. So she cannot see blackboard and then always rely on classmates' notes. So the second one will be improvement in device use. So because reduced screen time and use of 2 times magnifier reflects better near task adaptations. And then for the third one, it is independent in mobility because she can confidence in transport and daily activity with minor support. And then for the fourth one will be visual habit stable because she's quite consistent use of protective measure outdoor and continued digital engagement. So next slide. Okay, so some task-related history actually is missing or not recorded in the patient's sheets. Okay, so on the first visit, right, the task-related history was missing is, does the patient require assistance or hand-holding in outdoor or unfamiliar environment? Then the second one will be, does she needs guidance for jogging? And then, is she confident performing outdoor activities alone in unfamiliar place? And beside that, what digital devices does she use? For example, such as iPad or iPhone. And then what is the screen size of the device used, such as tablet or phone? And then does she enlarge the font size for better visibility? Also not stated in the log sheets. So what are her common activity using the digital device? For example, reading, drawing, watching movie, and playing games. And then the last one will be, has she ever tried using a telescope in class? So for the second visit, the task-related history were missing also is at what distance can the patients recognize faces? Then does the current spectacle aid in watching TV without needing to sit close? Does she require any support or assistance during sports activities? The next one will be, what type of sport does she usually engage in? Does she regularly visit the park? And also not stated in the log sheet as well. So what are her expectations from the low vision clinic visit? And then next one will be, does the current spectacle fail to improve her ability to see the blackboard in class? And then the last one will be, any difficulty navigating in familiar or unfamiliar environments. Okay, this is for the second visit. Okay, so next slide. So for the assessment part, for the first visit, okay, patient's present RX, right side is plus 200 with cylinder power minus 675 with axis 10. For the patients, for her left present RX will be plus 100 with cylinder minus 550 and with axis 5. And then patients unaided VA for distance will be 660 plus 2 on her right, and then 648 minus 2 on her left. And then VA for aided, VA aided for distance will be right 6/60 plus 2. And then left eye will be 6/48. And then both eyes 6/48 plus 1. And then VA unaided for near is record down as right eye can be achieved 3M at 30 centimeter and 2M at 30 centimeter as well for patients left. And then on the second visit, the present RX will be right eye plus 250 with cylinder minus 675 with axis 10, same. And then actually same with the first visit. And then the VA aided, the aided VA for distance will be a patient able to achieve right eye 0.92 logMAR. And then with pinhole, there's no any improvement and able to achieve 6/50. So which means have improvement. And then left eye able to achieve 0.9 logMAR. Pinhole also no improvement and able to achieve 6/48. And then both eye able to achieve 0.86 logMAR. Pinhole no improvement and able to achieve VA 6/43. And then VA aided for near, it is state in right eye able to achieve N12.8 at 23 centimeter and left eye able to achieve N8 at 23 centimeter. Both eye able to achieve N12.8 at 23 centimeter and reading speed is state down, it is 95 word per minute. Next. So on the first visit, okay, okay, thank you.
Okay, so basically the first visit in January, there's not much of the assessment being done. If you can see from the slide here, there is no retinoscopy was done in January. We go forward to the subjective refractions. You can see that on the right eye, there is not much of the difference. And then the left eye basically have gone out by plus 0.75, cylinder out by minus 0.50. Next. And there is an additional test being conducted in May where they did the cover test where there is a small exophoria, fast recovery, pupil polar, negative RAPD. Mortality is they found that there is nystagmus. Okay, the new point is outplaced. Color vision test 1414 Ishihara. Topography being conducted with a cylinder of minus 7.14 diopter on the right eye, and the left eye is minus 5.87 diopter. So there is basically some OCT being conducted on the left eye, both eye, with a CD ratio of 0.4. Slit lens, basically both eye have a MGD of grade 1, and anterior chamber for temporal is G4 and NASA is G4 as well. So for the first trial and the second trial, I mean the visit, there is a missing of the magnifications trial on the first visit. Then we can move to the May visit. Basically, a magnification was being done, okay, with a stand magnifier 6 times. VA achieves N5 and patient actually don't like that kind of magnification effect. And a handheld magnifier was been tried on the patient with a non-illuminated type. Okay, 3-time magnifications, VA achieved N6.4. 4-time magnification, VA achieved N5. Patient comments slightly blur. And 6-time VA actually is patient have a N4. Patient prefer this kind of magnification. Next. 请问
So yeah. So here we move on to the differential diagnostic on 2 visited, which is 1st of January and the 2nd of May. Basically, we see is actually not much differential. For the first diagnostic is nystagmus and low vision due to the nystagmus and albumis. So an evaporative dry eye for the first visit, and the second visit same is differential diagnosis is both eye nystagmus and RX change slightly, and the evaporative dry eye and also albumis. So now for move on to the management and the rehab for the first visited. So we are prescribed a new RX due to the lens coating damage and advised to use non-preservative artificial tears and do warm compression. So TCA for 1 year routine eye check. For the second visit of the management, so there are no RX prescribed due to the minimal change and no improvement in VA with new RX. So advised to change handheld magnifier to 6 times. Advised also on artificial tears preservative-free eye drops. So same TCA also is for 1 year routine checkup, eye checkup. So that's all for all our presentation today. Thank you.
Okay, thank you for the presentation. This is the patient's real name is Hidayah?
Yeah.
Hidayah, yeah? Okay. The second visit was not conducted by me. It was Mr. Azam. I wasn't here, so he conducted the second visit. I remember the first visit. Okay. Okay, we're going to discuss because this is albinism case, right? So we're going to discuss more on albinism. Okay. Before we take a break, okay, I'll give you one short assignment. Okay, first, you can Google. You'll find all the answers. Okay, what is the sign and symptoms that a patient with albinism will have, and how that is related to the condition that they are having? Okay, for example, okay, patient with albinism have high refractive error. Okay, how this? Because based on your statement in your presentation, you mentioned that albinism caused them to have this nystagmus and also high refractive error. I want you to actually explain to me, not only for the group member, but for the whole class, how this albinism leads to leads to this albino patient to have high refractive error, nystagmus, and whatever symptoms that they're going to have. Okay, so we'll take a half an hour break, for you to complete this assignment, and our discussion is going to be on this. Okay, at 10 o'clock. Kenna, I'll give you half an hour. You go take your coffee break, because after that, we're not going to have break. It's going to be discussion. So have your coffee break, and at the same time, do this short assignment, this down, and try to relate how this is actually related to each other. And then we'll start the discussion. Okay? Okay? We'll meet at 10 o'clock. Okay? After the break with the assignment answers for the assignment that I've given you. Okay, yeah?
铁斌，你关声音，听不到你关声。
OK，
哎，可以看回第一个 slide 那个把握那边一下吧，刚才的
第一个 slide，
那个他的 first visit 他的把握那些，
请问你要不要做 share 一下？
这个
哎，对，哎，上面那几个那个是他的
这个
第五
是
个 slide 是什么？第五个 slide 哦，是讲这个东西，看一下这个先啊。
Miss Indira 的 question 是可以 repeat 一下吗？
Urbanism 的 sign and symptom，
他是说 normally high refractive error 嘛，对吧？
对，
然后
然后还有什么的，好像 photophobia 啊还是类似这种问题是吗？
OK，它会有 phobia 的 hypoxia，还有他要知道更多的 side effect 啊。
关于他的眼睛，弄到他的眼睛是吧？是怎样会 affect 到他的眼睛？
High myopic, high astigmatism，然后还有不 hypoplasia，还有
那 photophobia 是因为他的 iris 跟 retina pigmentation
optic
black，
fiber，然
high
后会
astigmatism，
low VA，为什么这样导致这样？是因为它有 metropization process affected。哎，我昨晚开着我的 video，谢谢，拜拜。啊。
Miss, you are muted.
Miss Indira 应该是跟其他人 discuss 吧。
哦，看样子算是了。你有 make up appointment 吗 ？Low vision。
还没有啊。
有一个是外有几个是有一个是外州的，时间很难安排啊，他特地要 travel 下来。然后有一些是老人家不方便，家里也没有人得空，这样。再看咯。
我们要每个人自己 appointment 那些 low vision 还是 group 啊？那时候 physical class 哦。
我们要安排
包
到
里
slot
面的嘞
就可以了。就是我只有报里面的 Steven， 你有认识到人吗？你们那边有 low vision 的 case？
有，不知道他肯不肯来哦。
是咯，如果说是我们方便的，如果他行动不方便那些，我们可以去接送他啦，再不然就看怎么样咯。如果我们没有 fulfill 到这个 clinic 哦，看 Miss Indira 会有什么想法先呢？因为他想是我们去 fix 这个 appointment， 我觉得没有的话，可能过后我们也是要补 clinic， 就是可能过后再 fix 一个 schedule， 如果他有 appointment， 我们可能就要倒回去。
可是他说他有
剩下几个 patient， 每个 group 都要一个 patient。
每一个 patient 每一个 group 要一个，就是说一天里面如果有2个 group 在跑，所以我们就要2个 patient。所以如果我们有6个 section 的话，我们3天 clinic 嘛，所以我们至少要6个 patient。
所以 basically 我们每个 group 都要有3个 patient 哦。
对 ，Group A 要3个 patient，Group B 要3个 patient 啊。
可是他刚
So
才
far 是
说
confirm 是有一个了啦。Sorry。
刚才说他有 patient 嘛，对吗？
对呀，
他应该是有 backup 啦，不过
Why
他
not tell 他 patient confirm 先呢？
I mean 可能他是那种后面预备的咯，可能不是。
还是叫 Miss Indira confirm 先呢？叫他 confirm 还有 patient 了，我们就再另外找我们的 slot 的，可以吗？
可以跟他讨论一下啦。
因为他讲他的 patient 在等嘛。
哦，知道，等一下再跟他讨论这个东西了。我是觉得他可以 fix 他的先啊，因为我们没有这样多 low vision 的。
就是他叫我们从他的 file 找啊，那时候就是
我已经 WhatsApp 了6、7个了，所以有一些就是讲咯，我跟你讲的咯。有些办不到，因为他不是住这边的嘛。
要有人去载，这个是一个问题哦。
你去槟城载要不要？
我都我都不能载，我要去槟城。
有槟城下来没有的？他约，本来他是约上个拜一我想没有 clinic， 然后 Miss Indira 不在，就不能咯。嗨，没事。
嗨。
Okay. Sorry, Dr. Fu was introducing one machine to me. Okay. Shall we start with the discussion? But before that, Ching Woon texted me something in the group. What is it, Ching Woon? What is the clash, huh?
Yeah, at your Excel form, right? For the live physical, for the physical section. Wait, I open and see again. So the group A and group B, the group B mostly fixed on the 2 and 4 p.m. right, for the 7th of July. And then for the 8th of July is also 2 p.m. and 4 p.m. Right?
Oh, okay.
8th of July.
Terbalik is it?
Just terbalik lah actually. Then just which should we follow only lah.
Yeah lah. Wait, let me change now itself. Otherwise, I will forget.
And
so the A should be in the evening, B should be in the morning, correct?
I'm not sure which one you want to change the main timetable or the Excel form for your own lah.
No. This Excel main timetable already fixed. I will change this. Wait, I'll do it now. Otherwise, I will loop one all already.
So, yeah, because you asked us to confirm the patient, then
So physical session on 7 July is Group A morning, Group B afternoon. For 8 July, Group B in the morning. Sorry.
I think it should be alternate lah. What she meant is.
Yeah.
So like Group A Monday morning, then Tuesday will be even afternoon.
But one thing also, the 7th of July, actually for the Dr. Fu class is go for group B, not group C already on the main timetable.
Oh, yes,
Because their state is group C for morning class.
Okay, wait, wait, let me do one by one,
Okay.
Group B. 7 July morning is Group A. 7 July evening is Group B. 8 July is Group B. Okay, terbalik. Sekejap,
It's correct. What I see here,
Uh,
7 July, yeah, morning section is Group A, afternoon Group B. 8
8 July.
July, it's Group B first in the morning, then Group A will be the afternoon. That's correct. What? Nothing to
Yeah.
be correct. Only thing that the Group C, initially we have 3 groups, right? So
Yeah.
what Dr. Fu suggests is those who are not involved in the morning section for the clinic. So he asked to join under his PBL discussion. So basically the morning section on the 7th July, A will be attending the clinic. So B will be with Dr. Fu on the discussion.
Eh,
So alternate
8,
one, the 8.
8 July, B is morning. B is
Sorry,
morning.
7 is correct. 8 is terbalik. For the Miss Indira, you do the yourself one, the physical clinic section timetable.
Yeah. Wait, according to here is the new one, 8 July morning is Group B, evening is Group A.
Huh?
Correct.
Mm.
Correct. That's
Betul,
correct.
Okay, now the updated version is correct. Okay,
Betul.
so this one is settled, Okay, what you were telling, Chingwon, another one is?
The 7th of July should be group B lah. For the Dr. Fu class morning.
Oh, yeah.
No more group
Oh,
C, right?
Oh, Dr. Fu one, I'm not sure, because I think his one got A, B, C. If you see,
Who is
You-
group C?
that one I'm not sure. You have to ask Dr. Fu, because his one ada A, B, and C. You have to ask Dr. Fu whether he wants 3 groups or 2 groups only. That one confirm with him. Mine is only 2 groups lah. I've already changed.
Yeah, because
Okay.
according to Dr. Fu, they will according to your
Oh, yes,
group.
then you just double confirm with him and then make the changes, because yours is PBL is only 3 slots, kan?
Correct.
You need to confirm with him. Okay.
As our understanding that those are not involved in the clinic,
Yeah.
so all of them they will be with Dr. Fu, no matter they are group one,
Okay,
2 or
okay.
BC, that will be everybody will go
Then
to
you
Dr.
already
Fu.
have an understanding. Then I think should be okay. Go ahead.
Yeah.
Okay.
So
That one no need to change, I guess.
Yeah.
Okay.
Only that
Okay.
one.
So this one is timetable is done. So now you can start plotting the patient's appointment. Yeah. As soon as possible, because I need to update the patient who's waiting for my reply. Okay. Boleh ya? Okay.
How
Now
about
we.
you blot first? Then we can attend the patient, cannot.
because
No.
after our discussion just now, none
Uh-huh.
of us are have a
Getting yet.
fixed appointment yet. So they are also, we were following up again by today, see the final confirmation, whether they can make it or not. If can't, then you can carry on, Miss Indira. See whether you are able to fix the appointment. That would be better lah. Doesn't need to, you wait me, I wait you.
Okay, then I give the slot first lah. You all, I mean that patient is quite flexible lah. One patient, another 2, I don't know whether they're coming or not. So I'll try to find patient from my side lah. You all also
Sure,
try to
thank you.
find.
Yeah, I have
Okay.
few following up.
Okay, 8 July for Chi Yong, can you actually plot in first? So that it's easier. Because you already book right 8 July 4 p.m. Okay, please book that first so that I tak kacau that one, Okay.
I will plot it.
Okay. So whoever had the patient, you all block first so that we can, make the arrangement accordingly. Okay. Okay, coming back to this patient, Hidayah. Okay, can Chingwoon share the slide again?
Okay. Sorry. Can see, right?
Okay. Yeah. Can you make it full screen?
Okay.
Okay, go to the first slide first. Okay, so patient, I'll go to the first slide, the intro, the title slide.
This one?
Yeah. So patient is a 17 years old kid, right? So she's going to sit for SPM lah, basically. Okay, so go to the next slide. Okay. She came on first visit on January 2024 and then May 2025. So when she came for the 2024, she was referred by someone. I think Dr. Sundar, if I'm not mistaken. I couldn't recall, but she was referred by someone. Okay. And then she came on May 2025. What was the reason she came in 2025? Hey, just give me a moment. Huh? I think the patient is calling me. Give me 2 minutes. I need to shift tempat. Somebody is going to use my room. Wait, just give me 2 minutes.
等下傍晚那个 Doctor Fu 是 case discussion 啊。
Case
Case
presentation.
presentation
啊 case presentation 都是4点到5点半那个了。倒水啊，
换时间了，
改了
换时间了。
换了5点到6点半吗？
5点到6点半。
哦，5点到6点
Oh
半。
my god.
这个礼拜倒水啊？
我的灯，
你的灯还有水？你？
哎，我
Cast
哦，启用 cut 2个吧，可以3个吧？
应该是2个吧？
这2个吧啊。
我讲快快啊，应该可以3个。
我也是讲很快的哦。
因为这样子
第3个是谁？
哦，我特地我把我的 slide 我都不要做上走，这样就快快 set 的话。
知道你是啊，知道 Rainy。如果我们
因为
2个
我是最后一个礼拜了的，我是如果可
第
以的
3个
话，
是我
第3个是谁啊？
Kelvin。
哦 ，Kelvin，你再不讲话，我忘记你声音了哎，太久没听到你声。
太忙了。
现在被工作摧残，你会这样容易咩？生活。
对了 ，keep 到了，声音还 keep 到。
那你这样开心？
我那里开心。
我连续6天做工，然后又没有办法做到功课啊，连这个 slide 都没有办法搞啊。
对，累哦。
还好啦，还
可以撑下去。
嗯。
一边做工，老板就给你读书，有这种老板也很少见。
啊？
你在做工的时候读书做你的功课的话，有这种老板愿意给你做这样的东西的人已经不多了。
很少哦。
收发是可以，收发是可以的，只是说因为他的客人还蛮 frequent 进来的，所以做一下你就要去 serve 了，所以也不是很方便的。
如果我跟阿克说，再来是谁啊？
嗯，
就是到调频，如果调频你不能就再下一个。
我了就请问了。
我跟请问 shift 的。
哦。
燕丽燕跟阿卡说，如果意外2个人的话，就到 Kelvin 跟 Serene 第6个礼拜，然后就到
你的很短吧？
请问我跟 Alex 哦，第7个礼拜 physical。
No，然后就到 Steven 跟 Alex，
Steven
第一次Steven 跟 Alex。Steven 跟 Alex 之后 physical class 我们会有多一堂嘛，所以就到我跟你，应该加 Jerry， 就是Steven Alex 我 Harry，
我们是最后一个 cycle 了吗？我们是最后一个 cycle， 所以我们要在 week 7哦。如果能，我们就在 week 7搞定好咯。
我们5个应该是因为 physical class 有2轮嘛，对不对？2次。
目前它其实是 set 一个罢了，因为其他都是 PBL 来的。它真正 fix 是 fix 在我们 MPU 结束过后有1轮，然后拜5好像也有1轮。
对，2轮哦。
2轮。那如果说是我们可以搞定的话， then 可以尽快开始 next round 了，就是说 Kevin Siu 跟那时候 first two 那2个人就可以进入第2个 section week 7。
Okay, shall we continue?
Yeah, sure.
Yes.
Yeah.
Sorry, people shoo me out from my room already. So I have to go out to other place. Okay. Okay, coming back to the case, right? So this patient came in because she was referred from Dr. Sundar, if I'm not mistaken. Okay. Then so she came in January 2024 and then her second visit in 2025. And the second visit is why she's here? Why she was here on January 2025? Because she was preparing in
SPM.
SPM, so she needs some help, is it?
No stated.
It's not stated why she's here.
Yeah.
Okay, maybe it's just a follow-up only. Lah. Okay, go to the next slide. Let me review back the case. Okay, next slide. Okay, not mention how her appearance look like. Not mention whether she is having like a white skin, nothing was mentioned. Only mention albinism because albinism also got 2 types, you know. Not
No
mentioned.
mention. No.
Not mentioned. Okay, go to the second one. Next slide, sorry.
This one just now is this one.
Next. Next slide. Okay, no changes in the RX. Okay, next. Okay, next. Okay, so this is the last one, huh? Revision device trial. Got prescribed any, you know?
No.
No.
No, huh?
Change spectacle only.
Change spectacles only.
First.
But go to the previous one. She was actually prescribed. Okay.
Yeah.
Because I ordered from MAB for her and her brother. Okay, both of them are albinism. Okay, so we did prescribe, but it is not written here because at that point of time we didn't order anything. But I ordered from MAB, I remember. Okay, we ordered magnifier for both the brother and sister. Okay. Okay, now coming back to the question that I gave just now. So I just went through the case again so that I don't miss out any point. Okay, so how this nystagmus is related to the sign and symptoms that the patient would have. Okay, what is the first sign of patient who's having albinism? Number 1, anybody?
First sign.
Photophobia.
Photophobia is symptoms. You know the difference between symptoms and signs or not? Okay.
Yeah.
Symptoms means what is experienced by the patient. Signs means what you as an eye care practitioner, after you do assessment that you will observe on patient. For example, photophobia is what is experienced by the patient. So that is symptoms. While sign is, for example, a high refractive error. high IOP, what you observe after you do assessment. That is sign. Okay. So sign and symptoms have different meaning. Yeah, it's not the same. Okay, so number one symptom is photophobia. Anybody else?
Nystagmus.
Nystagmus is symptoms or
Symptom.
sign?
Sign.
Sign. You
Sign.
observe.
Yeah,
Okay.
also. Yeah.
Okay, nystagmus. Then high refractory error. Okay, what else?
How about the
Strabismus. Good.
how about the
Translucent
like fair
iris.
skin and all these things? Can it be a like observation?
Hold on a
That
second.
would be
Masuk je bilik, you buat. Just nampak dekat tepi same height, everything is same. Okay, thank you. Come again. Who was talking? Kevin was
Yeah.
saying something.
Yeah, say like the fair skin, like you can see their skin colors and
Yes. Like poliosis.
yeah,
Okay,
yeah,
iris is white. Okay, all
yeah.
that are signs.
Sign.
What do you observe?
Yeah, observe.
Okay, white appearance lah. Okay, what else?
Translucent
Iris.
iris.
Iris
Iris,
transillumination.
yeah.
Okay, iris
Iris.
transillumination. Okay, what else?
Fovea hypoplasia.
Fovea hyperplasia. So sign or symptoms?
This is a sign.
Sign.
You observe. Okay, fovea hyperplasia. What else?
Optic nerve.
High astigmatism.
High astigmatism. Okay. What else?
Reduced visual acuity sign.
Correct. What else?
Hypopigmented fundus.
Come again?
Abnormal optitis.
Not really.
Not really.
Hypopigmented fundus. How about?
Okay. Pale fundus.
Sign. They are poor depth perception.
Post strip. Yeah.
Poor depth perception. Good.
Yes.
Okay.
How about the contrast
Color vision?
sensitivity? Low contrast sensitivity.
Low contrast sensitivity. Yes.
Oh,
Color
yeah.
vision. No.
Absent.
How about abnormal optic nerve?
Wait. I answer one first. Low color vision. No. Okay. Color vision is not affected unless if let's say the refractive error so poor, then they're not able to see. Then it's possible. Otherwise, it's not affecting. The cones are not being affected. Okay. Mr. Steven, you say something.
Abnormal optic nerve. How about?
No.
How
No.
about the lens opacity? Because it's
secondary to nystagmus, patient will get cataract. Okay.
cataract. Yeah, correct.
Okay. Okay. That one I'll Okay, Kelvin, can you remind me to explain about this later if I forget? Okay.
Secondary to
Contrast.
Secondary cataract. Sorry, come again.
The contrast sensitivity, is it affected?
Yeah. Someone said just now. Already. Yeah.
Sorry.
Difficult reading small print.
Yeah, that is all involving the reduced VA. It comes under reduced VA.
How about the oculomotor?
No, that is assessment that we do. Their ocular motility is not affected.
Uncontrollable.
Someone said something.
Visually follow objects.
That is also not affected. Their ocular motility is not affected.
The patient mostly will be use head tilt.
No, that is not sign or symptoms. Head tilt. Not really. Unless if let's say they have a null point, then they will have it. So it's not common for all albinism patients.
Uncontrollable eye movement.
That is nystagmus.
Difficult in night vision.
No. This patient will not have difficulties with night vision unless they have some other ocular conditions together with albinism, then they will have. Okay, albinism alone will not affect that. Dia dekat dalam Thank you.
Is it will be affected with like the symptom like dizziness because due to the
Correct. Dizziness The feel like
headache,
the world,
migraine,
the feel like the world is shaking would be there for.
shaking.
That is
Yeah,
symptoms.
Okay.
yeah, symptom correct.
Vertigo.
And also migraine some more because due to uncorrected visions for quite some time if not corrected.
Okay. What else?
Misrouting the optic nerve.
Sorry?
Misrouting the optic nerve.
No.
To cause
No.
Can I say like something different with the vision one?
What?
How about the mentally health issue like
No.
they are quite afraid of things? No.
No. They don't have that.
Mm,
It's about their body system is not affected. Mentally they are fine.
okay.
The red reflex is very large.
Red reflex is very
And very bright.
no.
No.
There won't
I
be
believe it's
any
more dim rather than bright, right?
there won't be any foveal reflex. That will be one sign.
Oh,
Ah.
okay.
Okay, because the funda is not fully developed, kan?
Oh, yeah. Yeah.
Okay. What else?
Cornea
Watery eye.
irregulation.
Sorry. What was that?
Cornea like irregular, so that is contribute the high astigmatism.
Yeah. No cornea irregularities. The high
What-
astigmatism is because of something else, not because of the cornea problem.
Okay. How about the watery eye due to patient at the
That is
symptom side?
secondary. That is secondary. So
Secondary.
it is not, yeah. It's not for all albinism patients.
How about
I see.
abnormal head posture?
That is also secondary to the nystagmus that they have and also the
Nystagmus.
Nalgren point that they have. So it is not like common for albino patients. It's not like albino patients will have this. No. It is
Just
an
now already
adaptation.
mentioned strabismus issue, right?
Yeah. Someone said just now. Strabismus, I forgot. Any more? I mean, you can share this, whatever that you think that this albinism patient could have, then at least we can discuss. Otherwise, you will have like a one understanding that albinism patient is like this, they will have these problems. And then, if let's say you don't say that, right, whatever that you have in your mind, then I cannot clarify with you. Why is it a yes? Why is it a no? Anything that other than this that you have in mind that albinism patient might have this problem. Like, Mr. Steven is curious whether it's an optic nerve problem or not. No, I'll explain that. Okay, but it is a no. Anything else that a bit contradicting that you think that this patient might have this problem?
Sunburn. Skin. Easy sunburn.
The photokeratitis.
No.
That one is secondary, right? Basically.
Yeah, it's all secondary. Yeah.
Why
And
not? Sorry.
Sorry. Why not of why?
Why not the optic nerve and also the retina? Because of the pigmentations, the melanin's
Yes.
lack. The
Yeah,
glow is.
that one I'll explain. I have actually put a remark. Why?
Okay,
Because
thank
you
you.
have the doubt. Yeah, I'll explain.
Thanks.
Okay. Anything else that you have in mind? No, it's okay to share because that's how we
the
learn.
eyeball elongation status.
No.
No,
No,
right?
no. Okay, you will have the answers for all these doubts once I explain about what is albinism. Okay. Anything else that you have? You think the eyeball is in a different shape? Such things? No.
One more maybe is reduce the vision response.
No.
He cannot respond. Sometimes we. Oh no.
I mean, they cannot respond because they cannot see. It's
Yeah.
not because of some other problems, because the high refractive error. That is the reason why they are not responding as fast as other normal people. Not because it is some damages in the nerve. No, not because of that.
How about genetic? Can we ask like history taking genetic?
Yes, it is a genetic disorder. Okay, like this patient, right? Like the Hidayah, her brother is also albino.
Okay.
So the adik brother is albino, and they also have another third one also, albino. But we haven't seen that one because we saw the sister, and then we asked the brother to come. And then when the brother comes, then we got to know the other one also is also albino. So the whole family is like albino. The mother is okay, the father is okay, but the kids are all albinism. It's a genetic disorder for sure.
And they have immune deficiency,
Immune.
immunodeficiency because of albinism.
Yeah. Okay. They can have that, but it is not compulsorily everyone will have that. All albino patient will not have that. Okay, but certain comes together with the immuno problem, right? Then they will have this. But it's not like everyone compulsorily will have that.
Or is the X-linked inherited?
Yes. Yes, it is a genetic disorder.
And how about if the patient is a photophobia, then how we checking the eye? Normally we are using like slit lamp because it's all the lighting is related. How we
Correct.
can
That is the reason why if you see
assessment.
the assessment, right, it's very limited because many things we cannot do. It's not the students are not good enough or, don't remember or they missed out. No, it's because of the limitation that the patient has. Okay? Okay. Now coming to the, what is albinism? Okay. Basically, what is albinism is the lack of pigmentation in the body. Okay, the pigmentation, usually what we can find in normal people is the pigmentation on skin. Okay, pigmentation on, like, for example, we are optom, right? We know that there are a lot of pigmentation in many layers in the eye. Okay, we have pigmentation on our iris. We have some pigmentation in the retinal layers. So there are many layers that we have pigmentation. So all these are missing in this albinism patient. Okay, patient with albinism, they are missing of this pigmentation, and that is the one lead to all the sign and symptoms that this patient has. Okay, how is it related? So we go one by one. Yeah. Okay, so number one is, okay, what happened is when a baby born, right, the foveal development happens, until the classic age. Okay, so how a person's vision develops is, okay, when the infant is born, right, okay, the growth of the, the fovea is depends on the lights that goes in and fall on the fovea. So that's how the development happens. Okay, for this patient who is having albino, what happened is, the pigmentation where it's supposed to be at the foveal area, right, that is actually, okay, we have pigmentation in iris and also in the retinal layer. So the role of these pigments is to work like a sponge to absorb excessive light. Okay, it works like a sunglasses so that limited amount of limited amount of light only goes into the inner layer of the retina so that that information that is sufficient enough to be sent to the brain is the one that is allowed to be to enter the inner layer of retina. So what happened to this, patient with albinism is the amount of light that goes into the eye is, very excessive. Okay, what happened is when it is excessive, right, it lost its track of pathway to fall on the foveal area, which actually stimulates the development of the fovea. So because of the light is too much, there is no tool to actually absorb the lights. What happened is the light is scattered in the eye. Okay, supposedly this is the retina. So the light goes straight and then it falls on the retina and especially in the fovea. So the foveal development will happen. Okay, what happened to this albinism patient is the sponge is not working, okay, in the iris. So it still goes in, all the light goes in. And then here also no sponge. So there is no absorption place happening here. So the light that goes in, it goes in all direction. When it goes in all direction, there is no one specific place where it falls or directed to, which stimulate that particular area to develop. Okay, when that particular area is not being developed, okay, so the light doesn't go straight, doesn't go to the right pathway. So it's scattered all around. So that is the reason why this fovea is not developed for the patient. So when the fovea is not fully developed, what will happen is the patient will have high refractive error. high astigmatism, because there is no development, okay, in the foveal area, which is actually very sensitive to the clarity of vision that we have. When this is not developed, so clarity of vision will reduce, high refractive error, high astigmatism, will be, these patients will have that. That is number one. Number two is uh, why nystagmus on this albinism patient. Okay, one is, okay, when the foveal is developed, right? So there is like one line, the light goes in one line and it falls on the foveal, and then the information is passed to the brain. Okay, what happened to this, albinism patient is because the fovea is not developed. The light goes in, it's scattered all around. Okay, so what happened is this retina, right? It will be like, looking for the best place. Not the retina. Basically, the eye is adjusting so that the light falls on the most sensitive place so that the light can be actually transferred to the internal part of the eye. So what happened is because the eye is actually adjusting so that the light falls on the sensitive area, that is the reason why the eye is shaking all the time. Okay, because looking for the one sensitive part which is not existing over there. Okay, it's try to shake, it's try to move the eyes. Okay, so that when the light goes in, it can fall on one sensitive area which they don't have. So what happened is it actually shaking all the time. Okay, so that is the reason why they have the nystagmus. Understand better now? Now you know why is the yes.
Question.
Yeah.
Yes.
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 Thank you.
Means
Okay.
if, for those who is not albino patient, but the
Mm-hmm.
eyes having nystagmus,
Mm-hmm.
congenital means since born, so we can
Mm-hmm.
directly suspect the fovea is not developed well.
Yes, for sure. Okay, whenever there is an nystagmus, this is the reason. Okay, because it is not developed, the eye is keep looking for the sensitive area so that the light goes in, get processed. So that's why it is shaking all the time. Okay, so that's how we, that's why this sign and symptoms, right? It's very important for us to understand what could happen at the back of the eye. Okay, by understanding the sign and symptoms correctly, then only you able to actually predict something. Without knowing the sign and symptoms, right, you will be out of the track. Okay, so similarly for the congenital nystagmus, the same explanation, but then that for patients who are having congenital nystagmus, right, they have good pigmentation in the eye, but the foveal development is not full for that patient. Could be some other reason. Okay, that is a reason why it leads to this. Okay, but the explanation is the same. It's looking for the sensitive area so that the light can be processed, okay, by the retina. Okay.
Okay.
Okay, now you
Then,
understand why the patient is having a nystagmus and why high refractive error. Okay, now,
Sorry, I need to
yes.
clarification. It's
Mhm.
because the fovea only certain part of fovea is better developed than other parts. That's why the patient is looking at the best part to focus on the fovea, so is keep moving the eyes.
Yes, because fovea is the most sensitive part in the eye. Okay, that is where the cones are very sensitive. That is the reason why when you look at something, right? Okay, you're reading something or you're looking at someone's face, right? Everything look with good clarity is because of the cones existence. Okay, and also that cone's existence and the fovea is fully developed. Okay, if let's say that development is actually not fully, so the sensitivity of the cones and all that will be affected, so you won't have good clarity. Okay, when you don't have good clarity, okay, that's when all this eye movement, all that will happen. Okay, the clarity comes from the center part. I explained to you, right, about eccentric viewing and all that. Okay, I showed you the example, right? Where I tried ask you to try clear my face by using your peripheral vision, peripheral field, right? You can't do it because it is not sensitive. Fovea is the most sensitive part in the eye, okay, which give you the best clarity. Okay. Yeah. Okay. Okay, so this is the reason why, okay, when we look at the fundus, picture of patients who are having albinism, right? You will see them to have a pale fundus because there's no pigmentation. Okay, we have pigmentation in RP layer, macular pigment areas, all are pigmented. So now these patients, no pigmentation at all. Okay, no pigmentation even in the eyelashes. Okay, the eyelashes is also white, eyebrow is white, the skin is white, iris is white, everything is white for this patient. And this patient is actually, exposed to UV light a lot. Okay, that's why they have high risk of having cancer. Because, okay, if let's say you look at the prevalence of cancer, right? Okay, the prevalence of cancer, okay, is higher for someone who is actually having lesser pigments, a melanin in the body, okay, in the skin. So if let's say comparing me and you, right? I mean, all of you are Chinese, okay? The risk factor for me is slightly lesser. I won't say that I won't get it, but slightly lesser compared to you for skin cancer. The reason why is my melanin density is higher compared to yours. Okay, that's why I'm dark skin. Okay, so this melanin is a protection for the skin. Okay, it doesn't matter, wherever it is located. So this pigmentation is actually protecting your skin, from having the bad lights going in. So it absorbs all the negative lights. Okay, similarly for the eye also. So this iris, okay, the pigments that we have in the eyes, it actually acts like a sponge to absorb excessive light and also this harmful lights. Okay, for example, we have this macula pigment, okay, in the eye. So this macula pigment, it works like a sunglasses. Okay, it protects the eye from excessive, harmful lights from going into the internal part of the retina and damage further the
Yeah.
retinas. Okay, so this macula pigment is like a protection. So now for this patient, there is no macula pigment because they don't have pigmentation at all. So their, internal part of the eye, it's like an apple without skin. Okay, so this macula pigment, it is like a skin of an apple. Okay, until you peel it off, right, it will be like, the apple can stay like 1 or 2 weeks, without being damaged. Okay, but if let's say you remove the skin after half an hour, it becomes brownish, it get oxidized. Similarly, that's the role of this macula pigment that we have in the eye. Okay, once the macula pigment, lose its density, become thinner or become lesser, okay, the internal part of the retina is exposed more damages will happen. Okay, so every pigments that we can find in the body, whether it's eye, macula pigment, or is it in the body, there is a reason why we have the pigment. So macula pigment, the role is to protect the internal part of the retina, inner layer of retina, while iris is protecting the, it controls the amount of light that goes in. So it works like a sponge also. Okay. So when there is, a lack of pigments in the iris, what will happen is the amount of blue light, UV light, harmful light, um, excessive light that goes in, right? It goes in without a filter. So what will happen is when the crystalline lens is exposed to this much of, light, right? Excessive light, what will happen is it will lead, for the patient to get cataract. So that is the reason why usually when patient have albinism, okay, they have the risk factor of getting secondary cataract, cataract secondary to albinism. Okay, Calvin, now you got the answer. Okay, so that is the
Yes.
reason why. Okay, so that is the reason why this, uh, you know, uh, albinism patient, when they come into the clinic, yes, it is very difficult to do a slit lamp on this patient if, let's say, you know, um, they cannot bear with light, right? They have photophobias and all that. But at least before they leave the clinic, we have to do slit lamp and check whether the crystalline lens is okay or not, because they have high risk factor of getting cataract because there is no filter in the eye. They're exposed to too much of excessive light with all the harmful light, which lead them to develop cataract. Okay?
But
Miss
the
Indira.
patient have very suffering while doing the slit lamp, right?
Mm-hmm.
And they
Okay,
are
there are
very
many
difficult
ways.
to do the fundus also, right?
Okay, there are many ways that we can. Okay, there is a reason why I say this low vision clinic. It's not like a straightforward clinics like other clinics. You know, you do assessment, you know the answer no. Okay, if you can't do the assessment, you have to think of some other way of actually getting the patient assessed. Okay, that's why we do contrast sensitivity test. Okay, because if let's say the patient cannot be, we cannot do slit lamp means we do contrast sensitivity test. Okay, and then based on the VA that we monitor, during each visit will give us some idea whether this patient is having that or not. So we cannot solely depend on cataract. Okay, so there are many other ways for us to, know that based on the questions that we ask, during history taking. For example, okay, if let's say patient say that the VA, like if you see this patient, right, there is no drop in the VA. Okay, comparing to the first visit and the current visit, right, after almost 1.5 years. So there is no drop in the VA. But if let's say there is a sudden drop after 6 months, okay, that should be a alarming, point that, oh, this patient might have developed this. Okay, then you have to do assessment. Okay, if let's say you have done contrast sensitivity test, okay, for the first 2 visits, when you do the third visit and you see some drop in the contrast, then that also like a strong point that this patient might have cataract. Okay, so that's why I say you do it in other ways. So you need to find other alternative ways of doing assessment to actually at least get the doubt correct first before we do the slit lamp on patient when we don't have other option. Okay, and based on the complaint also, if let's say patient say suddenly only nowadays I have difficulties in seeing at distance or near, I feel like something is blocking my vision. That is also a sign that this patient might have this problem.
So, Miss
Okay,
Indira,
so we cannot depend on slit lamp only for this kind of patient. Yes, somebody wanted to say something. Who's that?
okay, Miss Indira,
Yes.
you say the albino for may be high risk to cataract, right?
Yes.
So is it possible that maybe like adult or 30 something at years old will need to cataract removed?
Yeah.
Compared to normal.
Yeah. It can be some kids that I've seen the albinism patients, they already like 8-9 years already got cataract, already removed cataract.
Okay.
So there is no
So-
age limit that it has
so
to happen at this age. No, it can be at teenage years. I've seen patient who is actually 17 years old who just did the cataract removal surgery because of albinism.
Okay,
It can happen at any age.
Okay.
Yes.
So there will be after you remove insert the IOL, then maybe after a few years still need to get PCO.
Yeah,
Then-
possible.
Okay,
Once you
possible.
insert IOL lens, anybody is having risk of getting PCO.
So after PCO still need to, because due to the patient maybe will be older and older, so maybe need PCO will be again and again, right?
Only
Once times.
Yeah, it will be like a recurrent thing. Okay, one, and also the only help that we can do is spectacles, nothing much.
Mhm.
And also, because IOL is already inserted, nothing can be done.
Yes.
Okay.
Miss Indira, since the albino patient is a high refractive error, is it the chance for them to improve the vision after the IOL insertion?
No.
No.
Okay. Why? Back to the basic. The foveal is not fully developed. Okay.
Oh yeah.
It is so like you give a glasses to amblyopia patient. Although you give the correct power, optimum power, if let's say the fovea is not developed, the patient is only can 6/12. Even if you give the optimum power, so patient will still see 6/12 because the development is not full. Okay, similarly for IOL lens also.
Miss Indira.
Yes.
Well, autorefractor works for patient albinos.
Okay. It works. No problem with that. No problem of using autoref.
Okay. Because last time you said that it's no use or not very works for low vision patient.
If let's say no, it depends. If let's say a patient is having congenital nystagmus, definitely. I mean, if let's say patient is having nystagmus, definitely doesn't work lah because the eye cannot fixate. If let's say if there is no nystagmus, patient can fixate, then okay, no harm doing it because you'll get some idea. If let's say they wear spectacles but they didn't bring, and then when you do red also you cannot see the um the reflex. At least from the outer eye you get some idea what could be the power, but although it's not going to be accurate, at least you get some idea that this could be the range of the refractive error of that patient, but it's not going to help fully.
Okay.
I have check eye with nystagmus patient. Most of them I can no problem. Every of them manage to get the auto reflection power. For the hypopigmentation, albinism is considered hypopigmentation, isn't it? So we got totally no pigment, or some of them partially got pigment, isn't it?
Okay, it depends on the in the severity lah. Okay, because there is no tool to measure whether they have like a 0 or they have like a 10% of pigmentation. There's no tool to measure. But according to the theory, there is no pigmentation lah. Okay, they are hypopigmented, but there is no tool to measure and say that, oh, this many percentage of pigments that they have, or no tool on that. So we treat them all equally, that treat them like they don't have any pigmentation.
One questions.
Mm-hmm.
Is it common that the albino patient coming with all those complicated combined together all those things, sign and symptom? No, right?
No.
It just like depend on the individual, that some of these albino patient have like 2 to 3 symptoms, and some of the patient having another. It's very late to getting all those, like we talking about the just now, all the sign and symptom together, right?
Yes. Okay. It doesn't mean that all albinism patient will have, all these,
Incomplete.
sign and symptoms. No. Photophobia for sure they will have lah. Photophobia is common. Okay. So that is the one common thing that they will have. Photophobia is for sure, high refractive error for sure. But whether they're going to have strabismus, eye pain and all that, it is not for all patients. Certain patients, the eyes are straight. So no issues with that. So they have like as Calvin said, so like certain people have like 2-3 combination. Another one will have only one. Okay, another one might have 4 to 5. So this not similar to all. Okay, so maybe the one Mr. Stephen Matt is the mild version one. Could be the reason. Okay, so we have the severe version of this albino patient also. Okay, so it depends.
Miss Indila, if
Yes.
let's say this patient, they don't have strabismus or nystagmus, that means their vision is still good. Their phobia affected or not, or still not?
No.
Not affected.
Basically, the phobia is definitely going to be affected, but how much it got affected, that's matter. Okay. Certain patient, after the correction, they might improve up to 6+. Their patients also, after give optimum power, their vision is 660. So it varies, so it's not similar. Maybe one patient after correction given, maybe it's only 6.9. Can achieve up to 6.9. So it's very depending on the the luck of the patient lah. How the system works and all that. So it's not that everybody will be 6.18, or everybody after the refraction is 6.9. Cannot, it's not like an exact thing lah.
Miss Indira.
That means for
Benjamin complete first. No, thank you for this group for bringing this nystagmus, albinism case, because we don't have like a specific lecture that explaining this. Good that you brought this in. At least you'll have idea of what is albinism patient and how to treat them, from the perspective of low vision. Okay, Benjamin, complete your question, Benjamin.
That means for albinism patient, their BA sometimes can be corrected, okay, to 6-12. That means their phobia is not affected much, is it? If let's say their phobia is very worse and a lot of not good, development is not good, that means they were getting a nightmares, is it?
Yes. Okay. Okay, this one is very subjective here. Okay, some kids, they have albinism, they born with nystagmus together. Some babies, they born, they have high refractive error, and then eventually after a certain time only they will have nystagmus. There are also cases where they had nystagmus until one time, then after that, they don't have nystagmus. Could be because of suppression or something, the eye stop moving. So I've seen these three types of patients also. Okay, so it is not like a distinct version that, okay, you must develop this. When your phobia is not developed, you will have high refractive error, then only you will have nystagmus. No, it's very depending on that individual.
Oh, they will recover from the nightmares also.
Not recover. It could be because of the suppression also can lead them to not have that. Because once the eye is already suppressed, no need to wonder where is the sensitive area, because this eye is not functioning. The information is not being transferred. So it stop working for that eye. So that also leads to this. So there are many versions of albinism patients that you will see. It's not like a distinct one. Okay, this is what will happen first, then next. No such thing.
So Miss Indira, the albino patient, right? Actually, the eye, due to the vision development, there will be effect also called the coloboma.
No,
iris
that is
defect.
that is different. That one is this one is not related. This one is more for yeah. This particular albinism is all about the pigmentation problem and what are the consequences of having low pigmentation in the eye. So that is the like cataract also, because there is low pigmentation, there is no absorption of bad light, which leads them to have cataract. So it's all related to the pigmentation only, nothing related to other than that.
Okay.
So, Miss Indira, most of the albinis patient is going to have hyperope power. Is maybe due to the
mostly
hyperope.
It's hyperope. Yes, mostly it's hyperope. Rarely I've never seen anyone with a did I?
It's because of non-developed optophobia.
Yes.
Not because of the eyeball range or eyeball.
No. This is all. That's why again and again, when coming to this albinism, right? Your thought process should, whatever doubts that you have, you should direct back to the pigmentation. Will this pigmentation leads to anything or not? That's it.
Okay.
I have patients.
Because when the phobia develops, right, by age, right, when the phobia develop, right, okay, it should actually towards the, from plus power to the myope. Okay, now there is no development, it's stuck there. Yes, Mr. Stephen, you want to say something?
I have patient with about 400 estimation of 450 nystagmus patient. Yeah, that's all. Just want to share.
Okay. Yeah, their astigmatism is very high. Like you see the current. Give me 1 second, Yong Hao. If let's say you see the current and the case that they shared also, the power is up to -600. Okay, so this is quite common because it's not developed. So the refractive error is very high. From what you have seen, it will be super high. -600, 700 is quite common among the albinism patient. It is not like something, usually you will see 200, 300, right? That one also consider high. This one is even more higher. Yes, Yong Hao.
Yeah. So, Miss, regarding the magnitude of these nystagmus, does it matter? I understand that the theory of the nystagmus is caused to the foveal development. So does it mean that the worst developed in fovea, it will bring a bigger magnitude of the nystagmus.
Okay.
Yeah, does it affect the vision? I mean, throughout this process, like I know there's a bit of touch up on the Benjamin
Okay.
question just now. You have answered because sometimes it might due to the suppression, so the nystagmus will be resolved and minimized. So I'm wondering, does it affect the vision switching, and
Okay.
then there is
Yong
a
Hao, your
power
question
flicking?
is actually, to answer your question, it is the other way around. Okay. Okay. Your question is the magnitude actually cause the vision to be poorer, is it? Am I understanding it correctly? Is the magnitude higher will make the patient's refractive error high or vision poorer?
Yeah, would it affect the
Okay.
vision? And also, does it, because due to the changes of the fovea, because that's my first thought. Then because you have answered, because it could be due to the suppression and then the magnitude becomes smaller. So I have a bit of doubt. Does the magnitude affecting the vision and all?
Okay. It's the other way around. The higher refractive error is the one that contribute to the magnitude. If let's say your refractive error is like very poor, right? That means, the processing is actually, very poor in that person. So that will be shown off in the nystagmus. Okay, the eye move, more because of that. Okay, so it is the other way around. Okay, this magnitude doesn't lead to the poorer vision, but the poorer vision is the one leading to the higher magnitude of
Magnitude of the magnitude, yeah.
Yes, correct. It's the other way around. But your understanding is correct, but just that you need to swap it to better understand that.
Okay.
Okay.
So which means that through this changing of the magnitude, it won't directly affect the quality of the vision and even the power as well, right?
No. Okay. 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 Repeat the question again. Just want to get it right if I listen it to correctly.
Because there is a unstable of the changing of this magnitude. So my concern, I'm just wondering if, let's say one day I have met a nystagmus case and then I prescribe power, but somehow this power will minimize this magnitude. So does it affect the power or maybe a vision getting better, or they are switching after some
That is
time
what we
because
want
of
to
the
do.
okay.
Okay, that is what we want to do. Okay, okay. The cause is because the foveal development is not full. That leads to the magnitude of nystagmus. Okay.
Right.
Now, we as an eye care practitioner, our job is to minimize the magnitude of the nystagmus. Okay, number one is by providing the correct refractive error. When you give the optimum refractive error, right? Okay, so the need for it to get a clearer vision is not that much. So it will be like relax a bit. Okay, I'm already getting a good vision because of the glasses that I'm wearing. So it's okay. So I'm just like, I need to tilt a bit, see, whether there is a little bit more to actually make my vision better or not. Okay, so that's why the optimum power prescription is very important, so that the magnitude is lesser. Because when they have this nystagmus, right, it's, although it's not going to affect in terms of vision, but the dizziness that they may have, right, it would be worse for patients who have high magnitude. When you give a good refractive error, the optimum one, you are actually making the vision the best version. But it's the best version, right? It moves lesser. When it moves lesser, right, the world doesn't look more shaking than it was before. That's what we want to do. Okay, so the idea is to reduce the magnitude by giving the optimum power, so that this eye doesn't need to work hard, okay, to get the good vision. So the question was good question, Yong Hao. Okay, now I'm just asking in general to everyone. Now you have understanding of what is albinism, right? Why they're having high refractive error, why they have nystagmus, why they have high astigmatism, why they have strabismus and all that. Okay, now I missed out one point of strabismus. Why do they have strabismus? Is similar thing. Okay, why they have nystagmus is high refractive error. Okay, when one eye is better than the other eye. Okay, same like amblyopia lah. I'm sure Mr. Azam have already explained this. Same like amblyopia. You have two eyes. One eye is good, another eye is bad. Okay, So what happened is this bad eye, right, will actually try to work hard to actually keep, working. But at one point of time, right, because it is like too much of stress for this eye, so this eye will actually give up on actually sending information to the brain. So what will happen is this eye will actually open. When you actually occlude this eye, this vision can still see. But what happened is when the transformation of the information to the brain, right? Okay, what will happen is this eye will send information. This eye will take all the information but won't transfer. So, okay, because it's tired already. Okay, so what will happen is this eye, right, because it knows that, I'm just doing my job, but it is not working after this. So it will take a eye turn, but not ready. So the eye will turn in or turn out. Okay, and this eye also will suppress. Okay, if you occlude can see, okay, VA you still can read, but information will not be transferred to the brain. That's when the strabismus suppression all will happen. Okay, for patients with albinism, because they've been working so hard. Okay, when one eye is better than the other eye. Now you know why albinism patient have strabismus.
Yeah,
Or you
in that
want me
case,
to
do we perform as a low vision? We need to anti-suppress, or we need to still keep as the optimum
No.
power?
Once the patient is already having strabismus, okay, basically we don't, in low vision clinic, we don't care about the battery. Okay, if let's say already I have an eye turn and all that, just forget about it. Our job is to maximize the better seeing eye to make their quality of life better. Okay, this strabismus case, all let BV patient, to be handled. When the vision is still good, when the vision is very poor already, right? No point touching this eye. Okay, like for example, if let's say the VA of this eye is like 612 and this eye is 69, you still want them to work together. But patient, when they become low vision, right, the vision is already like one eye is 660, this one might be 360. No point kachawing this one. Okay, so we usually ignore this. That's why I say we are ignoring for good. Okay, why do I say we are ignoring for good in low vision clinic is because the idea of the whole thing is this vision is already been tried by many people. It's not working. If let's say you're going to kickstart it again, right, it's only going to give trouble to these eyes, working pattern. Okay, so that's why I say always ignore the bad eye, because this one already tried many times and it's a failure. Okay, when it's a failure eye, right, you jangan kacau. BV is a different case. Okay, when it comes to BV clinic, the vision is still good, like 6/9, 6/12, it's almost there. You want to work together. You want the brain to actually still, work together, get all the information. But in low vision clinic, it's already like very bad. So ignore this. We concentrate on the good eye only. Okay, so that's why we have this classification of how do we categorize this low vision patient. How do we work on that? So we have like a different way of treating the patient. Okay, so usually we takachao the bad eye or the eye which is already turned, we don't bother about it. Okay. Okay, now can we move on to the management or not? Okay, but this is what you need as an eye care practitioner. Okay, what are you going to do to this patient? That's matter a lot. Okay, so this that's what we want to, that is what we want to actually, the purpose of low vision clinic. You already know the signs and symptoms, you already know how to do assessment, this patient cannot do many of the assessment, you cannot do that on this patient. Okay, but for this Hidayah, we actually managed to do retinoscopy. Okay, that one also we did towards the end. Okay, because we don't want to touch out her to have photophobia. So many assessment you cannot do. You cannot do people reaction test. You cannot do, even ocular motility test also you can do, but without the light lah. We agak-agak only. Okay, so we are not doing the proper ocular motility test with a pen torch. Okay, slit lamp cannot do. This phobia, hypoplasia, all you cannot observe on this patient. Okay, whoever that have done research previously, okay, have told that this albinism patient have phobia hypoplasia. But most of the patients that we see in the clinic, we won't be able to do, able to take the fundus picture. Why? One, they have nystagmus, cannot fixate. Even if let's say you want to do optal also, the light is going to be, going to be distracting them. It's going to cause them problems. So we cannot do all this. Okay. So slit lamp also very difficult. So whatever that is using light, right, it's very difficult for this patient. Okay. So we do the basic assessment, whatever that we could do. Based on that, we conclude the case and we do the management. So with a very limited data, we are going to actually, do something for them. So that is the reason why history taking is very important. So that will support with the minimal finding that we get from this patient. Okay. So albinism patient is very difficult to handle. Okay, because findings are very limited. Okay, before we move to the management, Kelvin has some question. Kelvin?
Yeah, correct me if I wrong. If I getting it wrong. So if like this, for first visit, then we already managed to get the spectacle for these albino patients,
Mm-hmm.
and then we realized that the nystagmus is getting lesser. Then
Okay.
after when the second visit, then the nystagmus is like recurrent to even more worsens.
Mm-hmm. Okay,
Then but the vision everything is still remain the same. So we not catch out on that nystagmus totally. So we just ignore the nystagmus.
okay.
Is it that means?
Okay, so we do two things together. Okay. One is okay when it comes to, okay, I'll answer this question during the management. Is that okay, Kelvin? If I missed
Okay,
out,
sure,
you let me
sure.
know. Okay. Because
Okay,
when I explain in order, then it will be easier for you. Okay.
all
So
right.
coming
Okay.
to the management, okay. So as an eye care practitioner, how do we manage this nystagmus patient? Okay. Number one is definitely refractive error need to be corrected to the optimum one. Okay, so that's the first one. Okay, so if let's say you're able to do retinoscopy, you do retinoscopy. If let's say patient is having, usually you cannot do lah. Okay, very difficult, or you do it to the end so that you will get some idea. Otherwise, we do a subjective refraction with the habitual correction that they have. We refine from that. Okay, so based on the refine, you all get one power. Then after that, the next thing that you have to do is do a ocular motility test. Okay, so ocular motility test is to determine what is the null zone point of the patient. Okay, if let's say, like for example, Hidayah is having an up gaze. Okay, you know that this patient is having, a null point at up gaze, right? Okay, I will teach you this again during our nystagmus class. Huh? So if let's say they have up gaze, right, what they have to do is they have to turn their head down. Okay, so that they can have the, basically what is null point is when you do ocular motility test, at which gaze has the least magnitude of nystagmus. That is the null point of that patient. Okay, so if let's say at the up gaze the patient is having null point, that means at that position the retina is more sensitive for the patient. Okay, because it is more sensitive, okay, that is the reason why the magnitude of nystagmus is lesser at that particular gaze. So what we're going to do, and we expect, if let's say the magnitude of nystagmus is lesser, we expect that area to be sensitive and we expect that area to have a better VA. Okay, so that is the reason why we want the patient to use that particular area to see. Okay, so that they have lesser magnitude and they also have a better VA. Okay, so what we do is you already do refraction, then you do a motility test, then you try to use ask patient to, like Hidayah, up gaze, then you have to ask patient to move their head, okay, down, opposite direction to the gaze. Okay, so if let's say this now is up gaze, then ask patient to move their head down. Okay, so move their head down and measure the VA again to the patient and see whether it actually showing any improvement in terms of the VA or not with the refractive error that you have given the patient. If let's say the nystagmus is better, VA is good for the patient, or VA is not good, but patient is more comfortable with this head turn, you ask them to use that head turn forever. You train them to use that. Why? Is because with that head tilt, patient would have a better comfortable vision compared to the straight gaze. Okay, so this is known to be the null zone training. Okay, so null zone training is you are training patient to use their sensitive area to use. Okay, although cosmetically it doesn't look good because patient has to tilt their head, they have to look at things like this. it might not look good, okay, but they will have a better, comfortable vision. And if let's say the patient don't mind and they want to have a good, comfortable vision, you can always train them to use that. Okay, so that's what we do for albinism patients. Okay, so albinism patient with nystagmus, this is what we do. If let's say patient is having albinism without nystagmus, then you ignore the ocular motility test. You can straight away prescribe and make sure that they get the optimum VA, and then they can use them. Okay, whether the nystagmus will come back or not. Okay, whether the nystagmus will come back or not. Okay, it depends. Okay, if let's say the patient, okay, albinism without nystagmus, come in, you give them the optimum power. Okay, everything looks good. The nystagmus gets lesser. You prescribe them. They come back after 3 months. You see the nystagmus magnitude is more than what it was before. Okay, there are possibilities to happen, but we have to look down. We have to look back at what is the cause that leading this. Okay, is it some other reasons that leads to the nystagmus to come back? Okay, is the patient having cataract or having some other problems that leads them to have this or not? First, rule out that. Okay, because once you give optimum power, it shouldn't go back to the a higher magnitude of nystagmus. There's something is not right. Okay, at the back of the eye, which leads to this. So that should be the investigative mind that you should have. Okay, if let's say patient comes back with a higher magnitude of nystagmus, although the VA showing similar to what you tested before you deliver the glasses, then something else need to be rule out. Okay, so cannot be it comes back lah. Okay, Kelvin, I already answered your question. So patient with the albinism and nystagmus, so that is what you have to follow. You do the refraction and then you do motility test. If let's say you have to train patient with null zone, you train the patient with null zone and try the spectacles again and see whether the patient is having a better VA or not. Okay, with the new head tilt posture. Okay. Okay, I have like 2 questions. Let me see if I can answer it. Can we use can. Okay, can we use yolk prism? Can, but it depends on whether the magnitude is enough or not to have the head tip. Okay, if let's say the patient happy with the gaze, but patient doesn't want to have the head tilt because of the cosmetic reasons and all that, then this will be the other option. Okay, but usually tilting head is will be usually. Why do actually I say tilting head is the first option? Because usually patient with nystagmus, right? Usually they will have this head tilt habitually. Okay, the reason why is because when they look at things, right, if they know that with this gaze they can see better, so whenever they're focusing at some things, right, okay, they will automatically will have the head tilt, so it become habitual for them. Okay, so if let's say someone who didn't know that they have this null point exists, okay, and you are introducing to them first that they have this null point and all that, if let's say they're not comfortable, then you can go for this option. So should be okay. Benjamin, is that possible? Null point getting worse gradually can be if other factors are involved. Okay, if let's say patient have null point then have cataract, then patient had null point but now having strabismus in both eyes. So that will make things worse. But otherwise, it should be the same. Kalau tak ada apa-apa, it should be the same. Okay, Calvin, I hope
So
I
which
answered your
mean,
question.
thank you so much. So which mean there will be like the null point definitely won't change from time to times. No, it will be just only like a certain angle, certain area, then there
Yes.
will be fixed for life.
Yes, correct. It's like uh, like a fake fovea has actually developed lah, with the maybe 1 or 2% better than other areas. So patient usually will prefer that area. If let's say they know that this thing exists, right? They would definitely, like for example, if let's say the vision is 660 with null point, you can see 638. Obviously, you want to use that null zone point because it gives a slight, better contrast or a better clarity, right? So definitely they want to use that area. Okay. So
Okay,
that
thank you
will
so
be
much.
yes, that is the null point. Okay, now coming to the, okay, what are the options that is actually available, for correcting or managing the patient with albinism? Okay, another thing that we have is prosthetic contact lens. Okay, prosthetic contact lens is also another management, but so far I've never prescribed any lah. Okay, because the patients that come to us is either scared of contact lens, or they don't have budget, or they're too old for it, so they're very comfortable with the current vision that they have. So I have never prescribed, but I wish I can do one lah. Okay, prosthetic contact lens means it is not colored lens. Yeah, colored lens is different. Prosthetic contact lens is the pupil size is actually, it is measured for the pupil size. Okay, so the concept of this prosthetic contact lens is to one, okay, to make sure that the light that goes in, it is in a one straight line. Okay, and also filter some amount. Obviously, this prosthetic contact lens is not going to work like a original iris for sure. Okay, but at least it will help patient to have a better, it's like a fake iris. Okay, so it works better than they have nothing. Okay, so that's the idea of this prosthetic contact lens. So this prosthetic contact lens basically, it's like a opaque black color with the center, opening, size of the pupil. So basically the idea of this is similar what I have explained just now, to make the light goes in and fall on the center part of the retina and make sure that that area is actually, being focused. So this will actually help them to prevent themselves, protect the eyes from having photophobia, because when it goes straight, right, the light is not scattered around. So it goes straight to the one point only. So the amount of light that goes in is limited, and also there is no lesser scattering of light in the internal part of the eye. So when there is lesser scattering, that the photophobia is lesser for this patient. Patient will have a comfortable vision. Okay. And if let's say it's prescribed at a younger age, right, the high possibilities, to enhance the growth of this particular part, right, is higher. Okay. So there are many benefits of actually prescribing this prosthetic contact lens. And actually, with the prosthetic contact lens, I've read one or two case studies regarding albinism patient being prescribed with prosthetic contact lens. It was actually conducted in UK, and one of my lecturer actually, published the paper. And according to that paper, that particular case study report, right, it shows that with the prescription for the a prosthetic contact lens, it's for adult, yeah, it's not for younger patients, the VA improves. Okay, according to the discussion based on that paper published, right? Okay, according to the author, it says that when you wear the prosthetic contact lens, you have like a small opening at the center. So this small opening goes direct, as I explained just now, go direct to one place only. So when the light is scattered lesser, right? So the confusion of the information that being transferred to the brain is lesser. So when the confusion is lesser, right? So the VA improves because they get, only the information from the center part of the eye. Okay. So that actually gives them a better VA. Okay. So this is what is claimed by the two papers that I read lah. So this prosthetic contact lens will help the patient to have lesser amount of scattering of light in the eye, which is actually lesser the confused information that is being transferred to the brain. And also the light that falls on the retina, it's only local at one place. Okay, so that will lead them to have a better information that is being transferred. Okay.
Hey, Miss
So that is
Indira,
yes, Benjamin.
sorry, for these cases, prosthetic lens, will you reduce the magnitude and nightness?
Yes,
Yes,
because
right?
yes, because the scattering of light is lesser and the light is actually going straight. That's what we want. We want the light to go in straight. We don't want the light is go in like a like bungee like that. Okay, we want it to flow like a river, not like a bungee like bush goes in. Okay.
Thank you.
Okay, Hanping got one question. When slit lamp cannot be used for albinism, we can use control. Any other types of example? No, we have limited. Okay, that's why low vision, right? In low vision clinic, right? You have to be smart. You have to be creative. You have to be, thinking out of the box. You have to find ways to, get this done. So how do we do usually is that's why I say, history taking will be the best. Okay, history taking is the best to detect whether the patient is having this or not. Okay, but from the questions that you ask, any sudden changes or not, because usually, right, this nystagmus patient, sorry, albinism patient, right, the VA, their their ocular condition is not progressive. Okay, that one you have to get it right. Not progressive means it doesn't get worse by time. Okay, it's not like that. They don't have development. Once the development is over after the plastic age, this much only their power. So the power will remain same throughout the life. If let's say something is in the VA also will remain the same, it won't get worse by time. Okay, because the pigmentation is not reducing by time, not there. Development done, finish. So they will be like stagnant forever. If let's say there is a fluctuation in the vision, fluctuation in the refractive error, sudden complaint of vision problem, like suddenly reducing, that gives a clue of what is happening. Okay, so that history taking is helpful for us when we do VA and we see, oh, every year same only, now suddenly there is a drop. Every year contrast is good, suddenly drop. So that gives us a clue. Although we cannot do slit lamp, and this will give us clue that yes. So maybe after the first visit you have the doubt, and then you ask patient to come back after 6 months, and then you see, yes, there is a slight drop again. Then you can actually convince the patient that I'm going to do slit lamp at the end. Okay, only for 5 minutes with a lower illumination. You still can convince the patient. Okay, and I'm not saying that you cannot do slit lamp at all. You can do, but in a modified version. And you have to inform the patient first why we are doing it. Okay, it is not like you do it like a routine eye examination. Okay, you can request. If let's say the patient is having something else, like having nystagmus, and then albinism, and then you do fundus, obviously you cannot lah. So that one only depends on the history taking. But Lam, you still can ask patient, can we do quickly one test or not? So you do with a limited time. You don't do other things. You only check the lens within 1 or 2 minutes, then done. Okay, so it's not going to affect them much if let's say they still can bear with some lights for a shorter time. Okay. If let's say really cannot, then you have to only conclude based on this lah. No choice. Okay. So
One
coming
more
back
question,
to
Miss
yes,
Indira.
Benjamin.
Sorry.
I know it's okay. That's why we doing discussion. Okay. Yes, Benjamin.
Okay. If I not heard mistaken from Miss Indira just now, say that for albinism patient, nystagmus for whole life, is it?
If they
Even
have
though
nystagmus.
yeah.
Okay.
If even sorry, if I prescribe protective lens for them, will it recover or not? Their eye will become steady or not?
Yeah, high possibilities. As I say, you prescribe glasses, okay, to minimize the nystagmus and also improving the vision. Once the vision is improved, right, the shaking won't be more because the eye is already corrected. But if let's say they remove the glasses, then you will see the nystagmus back.
Oh.
It is not like you prescribe, it will be like permanently gone. It's like, strabismus patient. You prescribe them with glasses, but once you remove the glasses, right, the eye will take turn again. Similar thing.
Oh, that means they have to rely on it.
Yes.
Okay.
So once the correction is in front of the eyes, you won't see nystagmus. Okay. So once you remove, then it will come back. Because without refractive error, the eye will be wondering, hey, where's the clearer vision? Where's the clearer vision? Once you expect, oh, no, ready, no need to move. So that's how it looks.
Thank you.
Okay, welcome. Okay, now you understand better what is albinism, what is the sign and symptoms of albinism, how do we manage this albinism, and what are the restrictions that we have with albinism patient. Okay, it's not easy to do. Okay, when you look at the case, right, very limited findings that they have, you might have doubted that, oh, these students must be lazy, that's why I never do. No. Okay, so when it comes to, albinism patient, okay, we only can do limited stuff. Okay, because if let's say that is if that patient is like very some certain patients their willpower is very high. Okay, if we ask, can we do this retinoscopy, 5 minutes, can we shine the eye, they still can allow. Okay, willpower is good, the damage is not so bad for that patient, so they still want to do it. Okay, they still allow us to do. Certain patient very sensitive, so when the patient is sensitive, right, even worse for us. Okay, even when you want to measure VA also, you have to turn off the Lokma chart. So it depends on, it's very individual thing lah. Okay, even in any cases in low vision clinic, right, it's very individual. If let's say certain glaucoma patient, they're very cooperative, you can do everything. Like your first patient the other day. But you might not see the same kind of patient, your second visit. They might have like a different, understanding and different phobias and all that. So it might be a different way of handling this. So it's very individual. Okay. But doesn't matter, how the patient is going to react, but you as an eye care practitioner, what you're going to observe, what you're going to actually ask the patient during the history taking, what kind of assessment that you do, okay, whatever that you do, your management has to be correct. Okay, even with the limited findings also, your management has to answer, the complaint that the patient is having. Okay, so it's you the one you decide of how to manage this patient. That's why we have this clinic. Okay, by the time you graduate, we all should have the same understanding. Even though I only able to do this slit lamp, but I know that this is the problem that the patient is having, and this is how I should manage the patient. Okay, similarly for second patient, you might be able to do a lot of assessment, you can get more findings that will make your pathways easier. Okay, that's all the difference. Okay, but the management has to be the similar one. Okay, so the management is, as I mentioned, one is, okay, first is refractive error has to be optimal for this patient. Okay, number two is the null point. If let's say the patient comes with nystagmus, then it's the null point. Third one is the need of the patient. What is the need? Like this Hidayah is going to school. Okay, what kind of help that she needs, based on her schooling days. Okay, so that one need to be provided. Okay, if let's say uh, uh, she's going to school and she has difficulty if let's say you look at the VA also, she cannot look at the small print. Okay, we do have albino patients who are in science stream also, yeah, so don't be surprised. So we had one patient who is in science stream where the mother came and requested from us, for a letter to do her science lab, physics lab, not physics lab, chemistry lab. We have these beakers and all that, right? You pour things, you have to look at the readings and all that. So she asked me to write a recommendation letter to request the science lab teachers, okay, to actually provide her with a beaker with, the reading in a big font placed on it. So I did write a recommendation letter for that student. Okay, so don't be surprised that this kind of requirement will come in, and based on the request from the parents and from the student, we provide the necessary things. Okay, like school examination hours and all that, the extended, we provide letters, whatever that is needed by the kids, we provide accordingly, according to the the findings that we have, and also from the complaint that the patient has given. So your focus when it comes to management, you should look back at the complaint that the patient has and how that actually been supported by the findings, the limited findings that you have, and then give management accordingly. If let's say you cannot manage the patient, you have to explain to them why I cannot help you with this complaint. Explain to them. At least when you can't help, they know what is the reason behind it. Rather than you discharge them with, wondering, why, this was not answered, or why they asked so many questions, but this one was not solved also. So you answer all the questions. Okay, is this the, wait, let me read is this the management, management of albinism, is it Rokia's paper? Or did I say? Management of albinism. Yes, visual disturbance in albinism. Yes, that's the paper. Prof. Rokia's paper. Okay, you can read that paper. Lah. Okay, there is one more paper also. I forgot already, but I should have in my folder. I'll share it to you when I have time. Kenya, how public can accept once the letter been written and dispense out? Will they yes. Okay, requirement changes according to age, Okay, we have this patient, not Shani, one more patient, he has been seeing me, this patient, right? He has been seeing me since he was in Tadika. Okay, Tadika, then he go to, primary school, then he went to, primary school, then, 9 years old, 10 years old, right? The letter changes every year, okay, based on the requirement. So when he was in Tadika, the requirement was different. So we wrote a letter. Then when he entered standard 1, then the mother brought him in. Then I say, you wait for 1 month, go to the new school first, and then see what is the problem. Then you let me know. And then she came after 1 or 3 months time. And then she said that these things are all difficult for him. So maybe he can write a letter. So I gave him. Then at 9 years old, different kind of problem. So the requirement changes if let's say they are kids. Excuse me. If let's say they're adult, right? Usually it doesn't change unless they change job, or if let's say, the near vision is being affected or the usage of computer become more now. So that kind of changes will happen. But usually the vision requirement should be similar only for this patient. So shouldn't be any problem lah.
So
Okay.
that which mean when we wrote the letter, then
It is
the
only for
receiver
limited
side,
time.
the receiver, they will be 100% accepted lah.
Yeah.
So
Because that is the Ministry of Education. They have a pekeliling, recently, after, I think for the past 4-5 years, right, they gave importance for the special education. There is one minister last time who gave so much of importance for special population kids. Okay, so when that time came, right, so there was one time the pekeliling, was released where they say that, okay, even if let's say special population kids, they go to normal school, doesn't matter whether it's a primary school or secondary school, okay, the teachers and the school management has to, they have to actually, make some, changes or provide some extra things,
adjustment.
the adjustment to this special population kids who are in normal school. Okay, so they have to actually accept and do it. If let's say they don't do it, they can, a complaint can be lodged on them. Okay, so there is a cleaning out ready, I think about 4-5 years ago, because
Mm.
my sister is also a teacher in a special population, for the kids. So she also told me that, got this kind of thing. So if let's say your patient needs and all that, you actually have, the authority to give the letter, and we have to follow it. So it's
Mm.
there is no restriction that, oh, I won't do and all that. No, it's a
I just worry
compulsory.
about if in future, if I return those a letter, then the letter being rejected
No,
with any
no.
reason like that.
If you are a certified optometrist, your letter actually, valid. Okay, and they have to follow
Mm.
it. Okay, because we do assessment, and then we know the condition, and the recommendation is given based on the need of the patient. So we don't just simply give. That's why, you have the you have the certificate one. So for sure, it has to be accepted.
I see. Okay.
Okay. How about the rest? All good? Better understanding about albinism. It's more like my discussion than your discussion this time, but it's okay because it's something new that you are learning. So I'm okay with that. Okay.
Very good discussions.
Yes, as long as because you're not like we optom students. I see them every week, and then whenever we have this kind of like extra times and all that, so we will sit and discuss this kind of cases. So we have limited time with you, right? So when you do this case discussion, so that's why I say pick something very interesting that you want to know more, like albinism case, right? So you rarely see, so you have a better idea now. So if let's say next time you have like a Stargardt disease, then we can discuss more, so that when this kind of patients you see them in future, right? At least you know that okay, I have learned this, rather than treating them like, oh, something very new, very peculiar. Okay, so that's the whole idea of this low vision case discussion. At least you have the background of, okay, this patient means this kind of things only they will have, and this is how we should manage it. Okay, so try to pick some interesting cases lah, so that we can have this kind of discussion. Okay. Okay, I think any more questions before we end the session? Sorry, I can kick out here, kick out there, a lot of breaks in between. I'm so sorry. Any question? No questions? Then we can end the session.
Yeah, that's all good for now.
Okay. Thank you so much. Okay. Regarding the grouping, the low vision case discussion missing session is only for Alex group, only one. Okay, I'll try to find replacement for that. Okay, and also for the, please update the schedule of the low vision patient. Okay, especially who was just Chi Yong. You can update first, so that I can give the other slots to other patients.
Okay.
We try to work on it. Try to convince your patients to come. Okay, because if let's say no patient, right, it's going to be difficult for you, because even you have patient, right, it will be very fun. We'll learn more things.
Okay.
Okay. Okay. Thank you so much. See you all. I will upload the link later. Okay. Okay. Bye bye.
Thank you, Miss.
Bye bye. Thank you, Miss Lee.
Thank you.
Any question
Bye
you can still
bye.
WhatsApp me. Like let's say you see any this kind of cases, right? You can always WhatsApp me. Discuss the case. Okay. Bye
All
bye.
right. Thank you. Bye bye.
Bye bye.
Bye.
Cheers.